Good morning. I'm Rene AMALBERTI, and today I'm commenting on human factors in patient safety, the ideal and the real. It's just true that we spent 20 years on this matter, and we have really done a lot. What we will see, and that's what the outline is telling you, is that this vision of success has led to bizarrely new problems, and now we have to adapt to a new situation, and we can try to understand where are the avenues for doing that. So if we start just about the history very quickly, what we can say is that we started in the 80s, and everybody is knowledgeable in the idea of CQI, continuous quality improvement on various Donna Debian and everything that was done on quality. And very quickly also came in the 90s this idea that we can have problems with complaints and litigation. And this was really a focus on adverse event in US first, with the idea of counting adverse event and reducing preventable adverse event. Very quickly, it came the idea, the importance of reporting adverse event, and also on developing methods for adverse event analysis. And this is, for example, what Charles Vincent did in this period of time. Very quickly after we started the millennium with deciding that safety is just a matter of following the rule, and we have to follow the evidence-based medicine, and in a way, safety is a search for compliance. Despite the idea was good, it is not that true that it is easy to be compliant with problems. And there is a good example with the N agent, where after decades of fight, we are still with 50% compliance in the real in the field. So it was a good idea, but it was probably too much simplified idea to just look at safety through the idea of compliance. And very quickly we started learning, and the best way of learning was to learn from other industries, and we did that. We compared the safety risk in medicine with the risk in other industries, and we quickly seen that we were at the back of the classroom. In fact, the average results was the result of a combination of some little areas where we are good enough, comparable or almost comparable to aviation or nuclear industry, like it is for anesthesiology, when anesthesiology is done alone, with biology, blood transfusion. But on the opposite, we had very dangerous protocols and solutions, like in oncology or in geriatrics, or even in schedule surgery, where we were just average. So the very result was to realize that we are a special industry. We are not like just railways or nuclear industry. We have reasons to be a little bit more risky. We are open every day, every night on all the territory. We are accepting all patients without consideration of the problem they have and the quality of the doctors and nurses we have into our medical setting. So it's probably one of the reasons why we had this problem, but we try to improve. And one of the first ideas was to think globally. And that's exactly what James Reason said. And it's very well known with the CHIS model, where we have active and latent failure. I don't want to comment too much, but in that section of time, in the early 2000s, we also imported a lot from the industry on the way of doing better. Example is a safer drug management, moving towards standardized concentration, re-engineering for safety, educating, reconciliating drugs. We also imported ideas from aviation, such as the one of checklist briefings, and we of course imported the WHO surgical safety checklist in the surgery area. We imported, and this was a little bit more difficult, the fatigue solutions that aviation was really using for decades. This is a good example of the limit of the importation, because when we did that with the days off after being on duty 24 hours, we had not the result we expected because of the staff shortage. When we had no physician, because they were resting after a time on duty of a day or 2 days, we had other problems with the absence of physician. So it's a good demo that you cannot just import ideas. You need to have the same envelope of context to really take the benefits. We did also a lot of importation on safer communication and teamwork. We imported the CRM, the crew resource management techniques from aviation. We imported simulation to train people, and really at the end, all these importation led to considering the safety culture, the importation of safety culture, the learning generative culture, and all what we have learned from the HRO, the High Reliability Organization literature, Carvey, Kathleen Sutcliffe, and more on all these spots that are really important to consider for having a safety culture into the hospital. The result is really not bad. We did a lot. We were thinking that we were improving very quickly. The reality was a little bit different, because we had to face a turning point in 2015, patient safety becoming more complex as we tackled a rapid change in the issue and complexity of the healthcare system. And really, the very reality is that healthcare needs to change. The transition time is very painful. Healthcare systems are undergoing transformation at unprecedented levels. In less than 20 years, the world population has climbed from 6 to 7.7 billion. It's plus 25%. Nearly 20% of additional patients are more chronic, more aging, more fragile. So we are not just augmenting the number of patients, but we are concentrating the augmentation on fragile patients that are needing more care. So the demand is really high. The hospital and healthcare system have not changed at the same speed, clearly. The knowledge and technology of care has changed at a high speed, but not the task force and human resources. It is sometimes the reverse. Progresses are made at zero cost, with the imperative of changing and changing again for reallocating means, resources, and finances. The GPD per capita for medical affairs cannot change that much, since it was already high before the last revolution. In a way, we were accustomed with an idea of rich vision, and now we have to do more with maybe the same money and maybe less money. Needless to say, medical workers are affected by these revolutions, continuously pushed to adapt. It is even greater challenge for quality and safety, since this dimension of care are only supposed to go one way, always more, and are not supposed to be open for any compromise and adaptation. What are the most important changes we have seen? The first point is that there is a need for a primary event-focused acute system to a longitudinal life course perspective. People are surviving problems. And it's very, very good. It's the result of what we did in the previous decades. We are now proposing to the population solutions that are much, much better than before. In a way, the problem we have are the result of the success of the past. We are making people surviving, but we are accumulating much more people who are surviving their problems for decades. And now the problem of patient safety and quality is the long term, not just the short term. And these are profound consequences for how we conceptualize safety and quality and reprioritize human factors. Just to comment about that, the half-life of medical knowledge is now below 6 years in most specialties. It is to be the half-life is just the time where for a very, very nice review in a specialty published in the New England Journal of a very high top journal, how long it takes that the half of the review is recognized as not updated and need to be changed. And this half-life of medical knowledge about now below 6 years is to be compared with the half-life knowledge in nuclear industry, 17 years, the half-life in aviation industry, 13 years. And the reality is that we are picking on shelves the strategy for quality in the nuclear industry or the aviation industry. So we are taking 10 years to make new recommendations and stabilize and teach them when the system is changing every 6 years. So you may understand the problem we have. We have also this big move to patient journey, which is very good in a way. But there are huge consequences for human factors in patient safety because it's changing the time scale. We are discharging patients much more rapidly from the hospital because we have the right technology and because it's very costly to keep the patients into the hospital and it's not for their benefits. So we are discharging the patients, but then we need these patients to find a general practitioner, to find nurses at home. And we are really new problems for transition of care, for primary care and home care. And we have to adopt a system vision and maybe and surely invest in domains we have not invested at the proper level until recently. Even the patient safety goals have changed because if we just consider the adverse event, the types of adverse event, we had probably 3 types a decade ago. Now we have 5. In the future, maybe we will have 10 or 12. The first finger is poor access. Of course, for long we had poor access because of the money, because of the inequity among citizens. But now it's another problem. You need to reach the right doctor at the right time. If you have a stroke, there is a new strategy asking for specialist radiologist and to resources, very high level resources within a period of 4 hours. This is very, very difficult. So it's a real new challenge for patient safety to find the right doctor at the right time in complex system, because it is not just for Tuesday morning, it is for all the week, all the night, everywhere on the territory. And of course, there are huge differences among these resources. We have the 2 other fingers and 2 next fingers that are very classic fingers about adverse event associated with poor care and with the care environment, such as the 4 infections, nosocomial infections. But then we have a 4th finger with poor shared information and partnership with patients. And this is changing because, as I said before, patients are living much longer. They are living 10, 20, 30 years after the big problem they had. So they need a plan for the long term, not just an information on what occurred yesterday. And it's not so easy for us to develop this information. And there are also incredible errors, never happens, that are the result of the complexity of the system. We have everywhere in the world impressive chronic staff shortage. It is not a problem of the Romanian, you have, of course, but it is a problem of France, it is a problem of UK, it's a problem of China, it's a problem of US, it's a problem of Canada, it's a problem of all countries. And working under staff and material constraints is becoming the norm around the world, with few exceptions. And the lack of personnel accelerates fatigue, disrupts teamwork, and concentrate the care on its technical aspects to the detriment of the more global care of the system. And of course, the COVID crisis, have aggravated the problem a lot. And if I just comment on the COVID crisis, it's just to say that despite the immense difficulties we have seen, adaptation and coping mechanism, demonstration, the medical professionals' power to adapt, evolve, and thrive, even in this time of unprecedented crisis. We have promotion of community cohesion and building strong neighborhoods, and we have used social media. We will probably keep in mind for long this advance of telehealth, and probably part of the telehealth will become a standard, despite it is still a problem for the payment scam and for other aspects. And it's not replacing the normal activity of consultation, but it's really something we have learned from the COVID. So I jump to my last point, and before jumping to this last point and speaking about avenues for progress, I just remind you about the two first points. The first point is that we have done a lot from the 80s until the starting millennium on quality and safety. We did very well, and the result, in a way, not just of quality and safety, but globally of medicine, has been to make people surviving problems. And this is very good. But once people are surviving problems, they are much more numerous, they are more demanding, they are changing the situation, and the medicine, the healthcare must adapt. And there is a need for a switch to a systemic vision and to a new approach of human factors in organization. So what impacts and what solutions? If I summarize, we know rather well the bricks of human factors and patient safety and their optimization. We have learned a lot from the past. Now we have to learn to use them to ride the house in the store, because we are in the store. We are transforming the system, and we have additional crises such as the one of the COVID, putting an incredible burden on the system. And we have two solutions. One is to continue believing in optimized adaptation, which is supposed to develop more demand and to develop more quality, more safety, and it's a demand of always more quality and safety. And that is a very temptation, because we want to do better than we did in the past. But the patients are more numerous, are more fragile, and we have to deal with more advanced and complex treatment and technology. That's one way, and we are pushing that way. But in the same time, we are pushing another way, which is the optimized adaptability. And there is a key word that is really inviting all our communication is resilience. So the system is in trouble, and we are tempted to bet on the individual capacity to adapt, the optimized adaptability. Maybe it's not in line with compliance. Maybe it's not really compliance. It's just intelligent adaptation to the real difficulties. This conflict of vision we cannot live longer with. We have to optimize science, patient results, and cost effectiveness. And we have also to optimize workers and systems, but we have to control these double optimizations, because otherwise there is a risk of having systems that are either totally utopist with only prescription and little reality, or systems that are giving the token to workers that are improvising. And it is not good for healthcare to have improvisation every day, everywhere. So the future is probably to use the full repertoire of intervention strategies in combination. That's exactly the repertoire we described with Charles Vincent in our last book, Safer Healthcare. It's a mix of very classic strategies, optimization strategies to encourage compliance, ensure best practice, develop best standards, optimize working conditions, but also on the other side, develop risk management strategy, restrain range of activity to that can be properly policed, increase risk control, adapt and recover, abstract intelligent adaptation to context, foresee and mitigate consequences of flows, and innovate. And the reality is not to make one choice among all these solutions and families, but to go through all the families at every time to find the best combination for really being in control. Thank you for your listening. And if you want to go beyond, you can read the Safer Healthcare. It is free from download, so easy to obtain. It exists in many languages. And also the other books I wrote recently, Navigating Safety. Thank you for your listening. It was a pleasure.